Thank you, Margaretha, Michael. Thank you for the nice introduction, and thank you for having me here. It's always a pleasure to come to EuroACHD to see so many good friends and colleagues. Mental health, that is exactly what I would like to address today. I have no disclosures. It is an open door if I tell you that mental health is an issue globally. And I'd like to show you some numbers that illustrate this. In 2019, and as far as I know, these were the most recent global data, 12% of world's population was suffering from one or another mental disorder. If you look specifically to anxiety disorders, it was found that 71% of the anxiety burden could be avoided when it was properly treated. So it clearly shows that mental health issues are under-recognized and definitely under-treated. And that comes at a cost, because if you look at the disabilities, the years of disabilities, then 15%, and also data from 2019, 15% of the years lived with a disability were due to mental disorders. These are data from 2019. This was pre-COVID pandemic. You can imagine what it would be today. What about the geographic distribution? This is how it looks like. There is a wide variability into the geographic distribution. But the interesting thing is you cannot pinpoint it to a specific region. It is not a purely Western thing or a high-income issue. It's not an issue specifically for the Global South. There is a wide variability. And you can even wonder those light green zones if this is due to the fact that indeed mental health issues are low, or is this because in China and Russia the numbers are not as accurate as we would want it. Why is it important? It's not important just only for the morbidity in itself. I said it comes at a cost in terms of disability. It also comes at a cost of mortality. This is a meta-analysis that showed that the mortality due to mental or related to mental disorders is high. There is a 2.22 relative risk of all-cause mortality. And if you combine this, those people with mental disorders do have the potential to lose, on average, 10 years of life. So if we really want to keep people alive, we should not only look at the heart, but we also have to look at mental health. This was about the global population. What about congenital heart disease, you would wonder? Well, last year we published an overview paper in this wonderful journal. And actually, in this review article, we addressed this issue. And the graphical abstract compiled all the information that I would like to share with you. Let's have a closer look at these. When you look at the studies that investigated the proportion of patients with congenital heart disease having depressive disorders, the range of the prevalence rates ranged from 0% to 27.3%. We are talking about depressive disorder, so it's a diagnosis of major depression. We are not talking about depressive symptomatology, because if you look at depressive symptomatology, the numbers are obviously much higher. Same is true for anxiety. Anxiety symptoms are much more prevalent than the numbers that you see here. Here we are talking about anxiety disorder, and that goes up to 35% of the population. Depression and anxiety are mental health issues that are investigated mostly in congenital heart disease. The other mental health issues to a lesser extent, but still, they are relevant to look at. Bipolar disorder, only one study looked at that, 0.7%. Post-traumatic stress disorder, we know that some of our patients go through traumatic experiences, and some of them indeed develop post-traumatic stress disorder, up to 3%. I was struck by this number, schizophrenia and psychosis, up to 41%, probably related to cardiovascular operations and that they develop post-operative psychosis and delirium. That's a possibility. Attention, conduct, behavior and impulse control, so the cluster of ADHD, up to 1/3 of our patients was diagnosed with that. Autism spectrum disorder, up to 3%. Eating disorders, up to 2%. But once again, only a few studies really have looked upon these things. Your question will be, but these numbers, are they higher than in the general population? Well, the number of studies that really did a direct comparison between congenital heart disease and the general population, these number of studies are limited. But when we focus on these studies, there are consistent findings in a sense that bipolar disorder, schizophrenia and psychosis, ADHD and autism had higher rates in congenital heart disease than in the general population. This does not mean that the lack of evidence for depression and anxiety means that there is evidence for a lack of a relationship. So it's not because we could not find consisting results in terms of a higher score on depression and anxiety in congenital heart disease that by definition this means that they do not have a higher score. At least future direct comparative studies can give some indications in this. Another question you may have is, do we see some differences according to the different heart defects? And the answer is yes. For this, I would rely on the results from Approach IS. Here we look at anxiety symptoms. So this is not about the disorder. Here it is the level of symptoms about symptoms of anxiety. And the most symptoms were found in people with cyanotic heart defects and Eisenmenger syndrome. The lowest level of anxiety was found in people with isolated aortic valve disease. And if we take this aortic valve disease as the standard and we compare all the other defects with it, you see that some differences are this small that they can be considered to be negligible. But as of the congenitally corrected transposition of the great arteries, Epstein anomaly, repaired tetralogy, and so on, the effect size was small, but this means not negligible. And for univentricular heart and the cyanotic heart disease, the effect size was moderate. When looking at depressive symptoms, also here cyanotic heart defects and Eisenmenger syndrome had the highest level of depression. Coarctation of the aorta had the lowest level of depression. And once again, certain substantial variability could be found, and the effect size of cyanotic heart defects compared to the coarctation was large. So there is indeed a large difference in terms of depressive symptomatology. The most dramatic consequence of depression can be suicide. Only, to the best of my knowledge, only 3 studies looked at suicide in congenital heart disease. Study in Finland, in Belgium, and in Denmark. And both Finland and Belgium found 3% of all the deaths were related to suicide. The Danish study found 0.5%, but this was based on administrative data. And you can wonder if administrative data are really capturing all suicides as they occurred. So at least this is something to worry about. This is something that we should scrutinize further. Is there something we can do about? The answer is yes. Last year, a Cochrane review was published looking at psychological interventions for depression in congenital heart disease. These authors found 3 randomized controlled trials, including more than 400 patients overall. And the overall conclusion was, yes, indeed, psychological interventions such as psychotherapy can reduce depression in people with congenital heart disease if you compare them with the usual care. And follow-up reached up to 12 months. So it is not only a short term, it's definitely also a mid-term effect. Hopefully, it is also a long-term effect. Of course, studies need to confirm this. The impact on quality of life could not be confirmed since the data on that were insufficiently strong. This means that knowing the high proportion of people with depressive disorders, to name one of all the mental disorders, knowing that we can do something about it and knowing that the therapies are effective, of course we should offer this as a treatment to our patients. But I don't know how it is in your country, but in Belgium definitely it is not easy to get access to psychological care. Waiting lists to psychologists or psychiatrists are long. And then the question is there a way how we can make psychotherapy more accessible to our patients? We are fortunate enough to live in a period of artificial intelligence. And 2 years ago, a review was published looking at randomized controlled trials where psychotherapy that was delivered by chatbots was compared with no psychotherapy. So it's not that the trials were doing chatbots versus human psychotherapy. That would not be a good trial either, I would say. It is chatbot psychotherapy or no therapy. And the meta-analysis showed, yes, it is effective. I am not pleading to replace humans by computers. But if we know how difficult it is to get access, and either you have the choice that your patients are having nothing in terms of psychotherapy, or at least they have a startup with chatbot-provided psychotherapy, it can cover the waiting lists, it can cover the waiting time until they get proper, more dedicated, more specific, human-provided psychotherapy. I'm sure this could be an answer for a lot of our patients. And knowing, once again, this is a meta-analysis from 22, including trials from the past decade, since ChatGPT and everything that is evolving in this field now, we know that more and better and more accurate systems are available nowadays than it was 10 years ago. So yes, I strongly believe that this could be an answer to an unmet need that there is today. Let me come to the conclusion and give you very brief, very clear take-home messages. Mental health issues at the global scale are an issue, and in congenital heart disease, they are prevalent. And therefore, mental health care is something that should be an integral part of congenital heart disease care. And therefore, mental health care providers are not nice to have, they are a must-have. Thank you so much.